Hello and welcome to episode 5 of our podcast series. We're joined today by the team at Sandwell in West Birmingham. This team took part in the Birmingham wave of the QI Collaborative, starting the programme in September 2020 through to completion in June 2021. In our conversation today, we'll be talking about the team's approaches to improving time in range, how they arrived at their areas for improvement, any difficulties and barriers that came up, as well as plans for future improvement. This podcast has been brought to you by the Royal College Paediatrics and Child Health.
So my name's Matt, I'm the Quality Improvement Project Manager.
Hi, I'm Karina, I'm the Project Coordinator on the National Paediatric Diabetes Audit.
Hi, I'm Dr. Chizo Agwu, I'm Consultant Paediatrician in Diabetes and Endocrinology, and I'm the Clinical Lead for Sandwell and West Birmingham Paediatric Diabetes team.
Hi, I'm Charlotte Avann. I am a paediatric consultant at Sandwell City Hospital, and I've been with the Sandwell Trust about a year and a half now with a special interest in diabetes.
Hi, I'm Lizbeth Hudson, Paediatric Diabetes Nurse, working at Sandwell with the team.
Could you give us a quick summary of your QI work? Just a very brief one about your main areas for improvement and your interventions, please, just to get us started.
So when we first started, we chose time in range as our QI project because we felt it would be one that would encompass all the things that we wanted to change. And we felt it was easy to sell it to our patients and our children because it's easy to understand, and it will have a positive impact both on their glycemic outcomes, and it will also help to improve all other areas of working of the team.
So what made you become involved in the QI Collaborative in the first place?
So as part of the network, the West Midlands Paediatric Diabetes Network, we're always trying to innovate and trying to try new things to improve our standing with diabetes and improve management within our team, within our families, and thought it would be a good idea to undergo the QI project.
I can also add to that. So we've done, like Liz said, we've done quite a lot of quality improvements before, but we haven't always followed a structured approach to quality improvement. So we saw this as an opportunity to learn more about the process of quality improvement to ensure that whatever change we made will be sustained. And in terms of the timing, it was also wanted to take advantage of the program that the Royal College was offering.
Oh, good, thank you. And just to get a rough idea, what kind of work have you done before in terms of QI then?
We have previously introduced carbohydrate counting at diagnosis. We introduced the Paediatrician app for our patients. We previously introduced, I'll have to think, we've done so many things.
Yeah, I think it's like we said, it's a less structured approach, but we're always trying to improve things, and it's working on the feedback from the PREMs, for example. Mm-hmm. So using the PREMs and any feedback that we do get, but it's a less structured approach. But we know that we're sort of trying to improve anyway.
I think that's one of our strengths as a team. Actually, we do meet together frequently. We do listen to each other's ideas and kind of brainstorm what we think is going well and what we think isn't. And we tackle things that we don't think are going as well as soon as we spot them. We try and implement some change, and not formally, but we are always looking at the outcomes of that. Has it worked? Has it not? What can we do differently going forward? So we're quite a proactive team in that respect. But like Dr. Agwu said, it's really nice just to have a more formal structure and some top tips from you guys really on how to do it a bit more formally and get a bit more out of it.
Yeah, so every year we have an away day where we refresh our philosophy as a team. We challenge ourselves to see whether we are meeting the things that we set out for ourselves. We review our National Paediatric Diabetes Audit. We review our PREMS audit. We review informal patients' feedback. And then we brainstorm to see what do we need to do differently? How can we improve our targets? And from that, we come up with all sorts of ideas of things that we ought to do. And we are usually one to just try it and see if it works. What we haven't done previously is measure formally and sort of using the PDA cycle formally. But we've always done sort of different things, like, for instance, improving the percentage of children that have our care processes. We implemented a form that our secretaries put in front of the clinics with the compliance for each patient, so that when a patient sits in front of us, we know exactly what care processes they have or haven't done, and then we're able to sort of implement it. And one we're working on recently is implementing care plans for the nurses to ensure consistency of approach when patients are admitted to our wards. So we have quite a long list.
It's really useful to know that, actually. I think it'd be great to kind of explore in depth a bit more about those interventions shortly, because I know there's a number of them with this project. But you said you were already an improving team to begin with, just needed a bit more structure about methods and to work with the framework. And Lizbeth, you took us into the PREM and NPDA data really nicely there, and that was the next question, and that's how you use PREM data and NPDA data to inform your ideas for improvement.
So we're constantly reviewing them, particularly as Dr. Agwu said on our away day, we look specifically at all our results. Also, because our trust covers two sites, we've got the city site and the Sandwell site, we always compare the data. And for example, this year, the HbA1c was slightly better at one site than the other. So we made sure we implemented some structure across both sites to see what are we doing differently, what are we doing better at one site than the other, that we can apply across site. So yeah, we find that data really, really useful, because I guess the downside to the data is it's always a kind of year retrospect. So you have to be looking at that as well as what we're doing more recently to get some useful way forward out of it. But I think, yeah, data's key, I think.
No, and it's great to hear, because it's one of the first things we do in the very first session with our teams is getting to grips with the NPDA data, and not least because Karina's here as well, who works on the NPDA, who'd be no doubt happy to
yeah, it's that. Brilliant to hear you using that data, and it's also great to hear that you're working with your other site as well. Did you borrow any ideas from any other services? How do you work well with your site and any other sites to help inform your ideas?
Yeah, so there is the national network, and they do have, whenever the NPDA is published, they get different teams to come and discuss different aspects of their report, what they've done well, what they've done differently. The other place that we get lots of ideas from is peer review visits. So whenever I've gone as a peer reviewer, I'm always on the lookout for what's going well, because sometimes you say, oh, okay, that's how they've solved that problem. So we are very happy to borrow ideas from other people if it seems to have worked for them. And as part of ACDC, which is Association of Children Diabetes Clinicians, we share ideas with other clinicians as well.
And then it's about thinking, I guess, what works for your own population. Because, yeah, each population has their own demographic in terms of ethnicity, deprivation. So it's finding what ideas you can pinch off other people that you can make work for your own population.
I don't know if you could hear a little bit more about some of the individual interventions that you came up with during the project in order to improve time in range.
Yeah, I can take you through this one. So we learnt about using driver diagrams in the QI sessions, which we thought was really, really useful to try and break down each stage of the process. So as a team, we decided the best way to improve time and range was to tackle it from a three-prong approach. So first of all, we wanted to increase the number of patients actually on CGM. Then we wanted to improve the ability of the patients, young people and their carers to self-care and empower them to improve their own time in range. And then the third prong was about improving staff support of CGM. So improving the confidence with training and interpreting of CGM downloads. So then using our driver diagram, we broke that down into further stages. First of all, those were our three main aims, and then we broke it down into what we needed to do to achieve them, actions, and then we make sure we have a specific person responsible. So improving people on number of people on CGM, we made sure we were identifying actively anyone in clinic that met the criteria. We started more CGM schools, and we've actually got through quite a lot of them, despite the pandemic, virtually over the last year. Yeah. We made sure that the staff were competent on initiating CGM schools by using the reps to help train them up. To improve and empower child and young people's self-care, we did a carb counting quiz, which we uploaded onto our Paediatric Health Zone app so that they could all do that. And the dietitians then targeted people who needed more input. We did our 5 golden rules to success, which we published quite widely, and including having a box on the end of all our clinic letters. So that includes things like making sure you're bolusing or injecting 15 minutes before you eat to try and improve your time in range. We also made sure we were upskilling our children and young people on the interpretation of their downloads so that they could look at them themselves. I think one of the beauties of time in range actually is it's very visual. All our young people know that they're aiming for blood sugars between 3.9 and 7, and they all know we've got a target of having 70% time in range, so they can see nicely when they open their CGM how close they are to that 70% and if they're heading in the right direction. So we made sure they all had adequate psychology input. We made sure they were all up to date with their pump quizzes, which again are on Paediatric app, so that they knew exactly what they were doing. And then the third stage, as I said, is about improving staff support. So we reinstigated the nurse-led phone clinics. We do CGM review slots with the nurses. We made sure all the staff were competent in interpreting CGM. So we had some teaching sessions where we went through them together to make sure everyone knew how to interpret them properly for our newer members of the team. And we also kind of instituted some things to make sure our team was working efficiently together, including, Liz, you did the Monday morning huddle, didn't you, as well?
Yeah, so I think with the wards, they were introducing a safety huddle on the wards, and so we just called our meeting a huddle. And it's a meeting on a Monday morning where we can distribute jobs out for the day. So any clinic people that come to clinic, if there's any jobs after that that week, for the following week or the week after, then those jobs would be dished out amongst the diabetes nurses. I think the meeting is really bonded, and it's a way of getting a lot of information out, and also how it's a chance to see how the nurses are feeling, if they're feeling overwhelmed or anything. So the Monday morning meeting has really got its roots set in. That was a positive step, definitely.
I wanted to highlight 2 aspects. I think the first was pivoting to doing virtual training during the pandemic, because that was quite a challenge to start off with. Weren't entirely sure how it was going to work out and exactly how the uptake and their knowledge base would be afterwards. So we did have to do a hybrid because we live in a very deprived area. We have children who didn't necessarily have the necessary computers or or smartphones to be able to access it. So we offered a hybrid solution where some patients could come face-to-face, whilst others could access it virtually. The other thing that I think has been a big bonus was our Health Zone app, which is the Paediatric. Just before the pandemic, the trust had bought or invested in the Health Zone app, and this was became really vital during the pandemic because we're now able to communicate with our patients through the app. So all our patient information were uploaded into this app. And prior to any of our trainings for CGMs or pumps, we had videos in the apps which they could watch as pre-training video. And any other resource we found really useful was uploaded in the video into the app. And the nurses also used both this app and the DAP app. And Liz might want to talk a bit more of how we use the DAP app during the pandemic, and it's become ongoing in trying to improve access to CGM and therefore improve their overall time in range. So this focuses mainly on their ability to self-care.
Yeah, I think the one app, the Health Zone app, it took a while for me to be convinced it was a good app, but then as soon as we Dr. Agwu is laughing now, as soon as we started looking into it, it was really, really good because the patients can fill in the forms on the app, and just by pressing submit, it is pinged to the team members identified. So the dietetic or the carb counting form, once that's filled out, that will be pinged over to the dietitians. The pump quiz, when that one's completed, that will be pinged over electronically to the diabetes nurses and the secretaries as well, in case so everybody's off sick or whatever. So it was a good way of saving paper as well, saving the planet. And we are convinced it is a good app. And also, just before the pandemic, we started learning how to use the DApp, which is the online training that the network put together, and quite a few people have purchased that as well. And that's a selection of videos that train the families on how to start to manage the diabetes.
Yeah, we've been using that quite a bit for our new patients, and generally they give good feedback because it's nicely in 2-minute video, so they can watch them in bits at a time, and they seem to be quite nice and easy to understand.
Yeah, another really important part was training the school staff in use of CGM. Again, we had to start to do that virtually with the help of the reps, but also signing them off as competent. The nurses put together training packages for children who are transitioning from primary school to secondary school, and those already in secondary school, to try and get them competent. And I'll let Liz talk a little bit more about that because it's her baby.
So prior to the pandemic, so for a few years, we had been organising school sessions in about July. So the school sessions in July were mainly for children going up into year 6, from year 6 going into year 7. So all the new schools that were having new patients were invited to these face-to-face sessions. They would go away with a care plan and all the training needed, and we'd do face-to-face practical, doing blood tests, injections, and showing them all that. In the light of the pandemic, we had to move to online. When it was face-to-face, there were quite a few schools that would join. Going virtually, we were inundated with schools, so we could invite pupils that were going, say, up in the year, and the schools were phoning us asking for training, so we would fit them into those sessions. And the ones in July, we had about 30, 40 people attending the virtual ones, and we put on weekly sessions in September as well, so that they could just add into the just join those virtual sessions as well. And those have been really really successful, the virtual ones, compared to the face-to-face ones.
So I think we targeted our project from so many different angles, which was why it was really nice in this process that we formalised it all down, so that we knew exactly which different angles we were tackling, who was responsible, and we continually kept a monitoring on it to see how we were progressing with each different aspect of the project.
And I was going to ask you about that, the project's management side of it, but I wanted to ask a question about the technology first, because the ones that you've mentioned, things like virtual training, a hybrid approach to that, a health zone app, training school staff virtually, and DApp, all technological interventions that are made to fit to make things more efficient and better cost and so on, but all new forms of technology and no doubt things that yourselves and your teams had to get used to implementing quite quickly. I just wondered how you managed that and how you supported your team in doing that.
So one of the things we started before the pandemic was we realized we had to learn together. There was no need, it was not useful to have one or two members of the team being specialists in something and not carrying the team with them. So every Tuesday we have something ongoing that is either patient-focused or learning. So once a month, we have a session that is just about learning as a team. And so one member of the team will present something, another and on a rota basis, or we'll have external people teaching. So that's one way we try to upskill ourselves. Again, in the away days, one of the things we look at is our skill set to see if there are any gaps as a team that we have as a skill, and if there are things that some different members of the team have to go off and learn about. With the pandemic, we all had to pivot quite quickly, and we all had to learn very quickly. Doing virtual consultations, that had to be done very quickly. And it was very difficult because during the pandemic, we were all working from different sides. So that cohesion that you normally have from your face-to-face team meeting wasn't always there. But because we had new members as well starting, so that was difficult. So I think one of the things we decided right in the middle of the pandemic, I realized that we needed another away day. So we did have to have an abridged away day because we had so many new members starting. We had all these new things that we had to do. And a big part of the away day was just well-being. How are we? How are we coping with all of this? And just being able to say it is difficult. And these are the things that we can do. And these are the things that we can't do, but also accepting help. So prior to the pandemic, a lot of our pump starts and CGM starts were done by ourselves, but we realized that we needed help with the reps who were perhaps more able to deliver some training virtually. So again, that bit we did hybrid. So we changed our timetable so that some of the practical aspects they delivered virtually, and then we delivered the core content in terms of targets and what we wanted our patients to be able to do. And one of the good aspects of the Health Zone app is that we put in a feedback form there, which again, they could just ping back to us as to how it's going and what we need to change. And it's fair to say that the course has evolved over time. It's not the same course we delivered at the beginning of the pandemic that we're delivering now, because you think, oh, that didn't work so well, or actually that worked brilliantly and we just need to keep that.
And I think of all the negatives of the pandemic, actually one positive thing that has come out of it is it has accelerated the need for change in technology, that we've done it a bit faster than we probably would have already done it. And we've had amazing secretarial admin support as well from Julie and Angela, who've really helped kind of keep us up to date with the app and things like that. And I think the other thing, as Dr. Agwu said, is making sure we're getting feedback from the patients, from the families, from the teachers and from the team about how they're finding things, so we can continually evolve going forward.
That's great. It sounds like you've got a really multifaceted approach to achieving your aim of improving time in range. And you mentioned having these away days, which seemed really helpful. How did you, on a day-to-day, weekly basis, come together and collaborate and manage the project and, see how everyone was doing, make sure that you're on track to meeting those aims? How did you come together more regularly?
So I think that too, during the pandemic was difficult, but we already had a structure where we have our secretary or database coordinator, Julie. I think everybody needs a Julie.
Yes, everybody needs a Julie.
Who manages our timetable and makes sure that things happen. So one of the keys to success was that we made this business as usual. So it was incorporated into our normal business thing. So we didn't have separate QI meetings, but because we meet fairly regularly, we have weekly meetings for different things. It was now incorporated into our business as usual, because all the things that we were trying to do in this instance was part of what we would want to do as business as usual. The extra bit was making sure that we sort of analyzed our outcomes, which is something Charlotte was doing. So looking just before our sessions to look at the data, because we could now quite easily get our data from the platforms to see how we're doing.
Thanks. I'm just going to take it back to measurement there, because Chizo, you said at the beginning that we needed an approach to measurement, and Charlotte, you mentioned there about patient feedback in your earlier response as well. And bearing in mind those interventions that you put together, then some of them quite new, how did you measure their effectiveness, and what kind of and I guess what was your approach to finding out whether they were effective or not?
Well, I guess the one thing that the being part of the formal QI project kind of forced us to do that we might not have otherwise is to kind of regularly audit where we were. So like Dr. Agwu said, actually, it was quite easy with the Libre View, the Dexcom Clarity and the Diascend to have a quick snapshot of where we are with time in range at any one point. So I think, if every 1 month to 3 months you have a quick look and see what percentage are achieving our desired aim, you know where you are and you know where you need to go. And because it's a bit fluid, if you're dipping 1 month, you need to pull it a bit tighter the next month. I think we set ourselves quite smart objectives to start off with. We were quite ambitious. We wanted at least 30% of our patients to achieve 70% time in range. And we were aiming for 50% of 60% time in range. We didn't quite meet this, but we did definitely show some improvement, which actually spurs on the team to do better as well. In terms of the kind of qualitative feedback, some of it's just informal, asking people at the end of the session how it went for the nurses, how it went for the patients, but also, again, our secretarial and admin support quite often sent out some questionnaires and things of how we're doing as well and how people found things.
I think in the face-to-face, when you're doing the face-to-face starts, you can get them to fill out the form before they leave. But with virtual, they've got the option not to, so it's just keep sort of that
little bit more tricky.
Yeah.
Yeah, I think the other thing, because in all this, we wanted to improve our patient knowledge. So one of the things that we continue to do is the pump quiz, which is in our Health Zone app. It used to be in paper form, but now is in our Health Zone app. And that's now integrated into our clinics, so that at least 2 to 3 out of their 4 clinics, for those on pumps or CGM, they undertake a quiz to check their knowledge. And so we're able to then see where the gaps in knowledge are, and then so that in the clinic you just focus on where the gaps in knowledge are. So this has become business as usual and integrated as part of our clinic, the way we run our clinic.
So you're getting constant feedback on the results that you're getting from that process.
Yeah.
Oh, good. And this is a question I probably should have asked at the beginning, but when I see time in range, I kind of think, why time in range and not overall HbA1c, and why has that been used as a measure instead?
Yeah, so HbA1c is a retrospective indices that looks at your outcomes over the last 3 months. We know it's very important because the DCCT has mapped it to long-term outcomes. Time in range actually tells you about how you're performing now. We also know it's important because we know that 5 to 10% improvement in time in range does map to improvement in glycemic outcome. And we also know that studies that have now shown that your time in range can be mapped to long-term outcomes. More importantly, patients understand it. So it's a really good tool for encouraging self-management. They can see it on their app. They can see the impact of what they do on their time in range. So that's one of the reasons we chose it.
I think also it's quite useful in a pandemic as well, because we can look at their CGM downloads remotely and see their time in range on the graph. We don't have to bring them in and do an HbA1c. So it's quite useful. It's also, like Dr. Agwu said, very in the moment. It can improve from week to week, whereas the HbA1c kind of is 3 months really, or at least 6 weeks before you see any change in it.
And I think if you've got the time in range, and we've shown patients where to look for that time in range, just the smallest number improvement will help that family if they're struggling.
I think that illustrates really well what our approach is to measurement in QI by collecting data like time in range that gives us real-time feedback. And this enables us to view what's happening as we go, rather than the type of measurement that we conduct with research, where, for example, we collect batches of data before and after an intervention to look at its effectiveness.
Sorry, another reason is we know that there are ethnic variations in HbA1c, which we don't see in time in range, and we live in a very diverse neighborhood. For instance, about 0.5% of the changes you see in Black ethnic minorities in HbA1c is really due to non-glycemic factors. So just focusing on the time in range takes that out of the equation.
You talked about how, I guess, surprisingly in some ways, COVID lended itself to some of the methods you were using, some of the apps. Were there any challenges that came? Can you speak to some of the challenges from working during a COVID time? You've touched on it a little bit. For example, with being able to give feedback in person, it's much easier to give someone a form. Were there any other obstacles that you faced?
Yeah, there were a few. Staffing was a problem. The fact that we had staff isolating during the pandemic, we had staff ill with COVID, and so that we had to manage. From the patient's point of view, initially at the beginning of the pandemic, they were quite motivated. Just before, as soon as the lockdown came, one of the first things we did was contact every patient, ensure that they were updated on sick day rules and so on. So initially they were really very motivated to do their best, and we saw marked improvement. But by the middle of the 2020, there was a significant tail off because this seemed to be going on for longer than anybody anticipated. And also they interpreted the virtual consultation, some of them, as not quite so important. So you would contact patients for a consultation, and mom would say then they're sleeping in the bedroom and wouldn't actually be keen to wake them up. They would pick up in environments that perhaps don't lend themselves to concentrating and learning. So that was a challenge. And I mentioned the fact that we had new staff starting in the middle of the pandemic. So there was the challenge of trying to upskill the staff. There was the challenge of trying to get them to gel with us as a team, which is why it became imperative that we had an away day in the middle of the pandemic so that we could actually all come together and see ourselves and talk about what we needed to do differently and what was working and what wasn't working.
I think also diabetes does to get really good diabetes control, it needs some kind of routine. And I think a lot of our young people were just completely out of routine and quite low in morale, some of them, towards the latter parts of the pandemic. So that doesn't really help with their motivation for their diabetes management at all. So that was one thing we needed to work at. Also, the massive influx of patients, which I think everyone's found most places since the pandemic. So we normally would have 35 new ones a year, and we were up to 55, 60 new patients a year. So just the sheer workload for our team, along with all the other pressures of the pandemic, because obviously new patients need a lot of intensive input, because we're very much of the ethos they need to get it right from the start. So it's quite a lot of work for the nurses and the dietitians and the doctors in those first couple of months. Trying to manage that along with everything else that's going on, and while continually trying to improve the team and the service, definitely was challenging, I would say. Wouldn't you agree, Liz?
Yes, definitely. And like Dr. Agwu said, I was shielding during the first lockdown. But it is quite weird when you're doing a clinic in your office bedroom, and the consultants in their office bedroom or whatever, and you're seeing patients. It really was surreal at the time.
Yeah, it sounds like it. It sounds like you as a team were under quite a lot of pressure and stress. How did you stay motivated to continue with your QI project?
I think our philosophy has always been to go to the extra mile, and that's why it's always important to refresh that philosophy at every turn when we're struggling, to say, do we still buy into this philosophy? What do we need to do differently to help us to live up to the philosophy? So I think that helped, and also acknowledging the challenges. And so there were some things that we felt, okay, in normal times, this is what we would normally do, but these are not normal times. Maybe we'll stand this down. And focus on this aspect. And those are conversations that we had to have and also agree as a group. So it's just lifting each other as best that we can, really.
And I noticed as part of your organisation as well that on your driver diagram, on the rightmost column, you've got the person responsible for each one of those tasks to be carried out. And I think that's the first time I've seen that. Was that? I'm just very interested in your everyday approach to the way you organised everyday project management.
Yes, I think if you allocate tasks, then and also have a forum where people feedback on what they're doing, it kind of ensures that it happens. Where there is, if it's just left for everybody, then maybe nobody will take responsibility. But actually, the whole team does contribute to the success of the team. And I think as a team, I find that if people feel that they're stakeholders, then they're more likely to pull together. Whereas if people feel they're bystanders, then what happens if the one or two who are doing it fall ill or not there? So you've got to get into a situation where care carries on regardless of who is there. So first, everybody knows what's happening, and everybody knows who is responsible for what. So for instance, organizing the education and training fell to one of our more junior PDSNs, which she relished and organized it beautifully. And also it helped to empower them to present at the sessions, which was, initially was quite nerve-wracking for them. It would have been easier to just ask the senior consultants or senior nurses to present, but because they were organizing it and they wanted to be able to show the other more junior staff that they can present as well, and it's okay, it's a safe place to present. You don't have to be ace at anything to have to present to your peers and so on. So.
Thanks, and we're actually coming towards the end of the conversation now. So last couple of questions. Wanted to know a bit about your outcome data, the overall achievements you've made from being part of this project.
Yeah, so I think there are quite a number of things that we achieved, but I suppose the main thing that we wanted to achieve was improve time in range. And that moved from, so time in range above 70%, moved from 9% to near 20%, and time in range above 60%. We improved that by a 7 percentage point. So this was between January to July of 2020.
So we haven't quite meeting our target, but it's still an ongoing process, and we're definitely heading closer towards it, which I think was the ultimate aim. And generally positive feedback from the team and from our patients and families as well.
And in terms of number of patients that we put on CGM, that also increased exponentially.
That's a brilliant achievement, several achievements that you've made there. What are your key recommendations for other teams who might be taking on a similar project?
I think the first thing is to spend a lot of time refining the question. So what is it that you want to improve on? And why do you think it's an important enough topic to improve on? And then the next thing would be trying to work out the driver diagram to identify all the various aspects of that you want to improve on. So I would encourage any team that wants to take this on to learn the process. It certainly helped us to look at our processes. It helped us to innovate. And it helped us to introduce so many new things at a very difficult time.
I think meeting regularly is the key as well, to make sure you've got everyone's input, everyone's buy-in, and then as part of the kind of PDSA cycle, continue evaluating what's working, what's not, how can we modify it to go forward to improve things further.
I mean, there was a couple of things that didn't work with the Monday morning meeting and how we would get the tasks and the jobs from clinic out there. We tried one thing of emailing the nurses the clinic list and the jobs from that clinic list, and that didn't work. So in the end, we verbally handed out the tasks at the Monday huddle. So it was a case of trying this. If it didn't work, not leaving it too long before you tried something different.
What's next? Do you have any other ideas as to what you'd like to do next in the next few months?
Yeah, so one of the things we're looking at is because the National Paediatric Diabetes Audit has highlighted health inequalities in access to technology as well as the NPDA. So we're doing some benchmarking at the moment to see whether that applies to us. And B, with our Health Zone app, our next thing is to make sure that we have videos and information in different languages, in the key languages that we have, so that they can access it. One of the things, we had some money left over, and we've bought some laptops, which we hope to give out to some of our families that can't afford it. So we're trying to focus on health inequality to try and bridge the gap as much as possible. We have done doing some work with ward, improving the standards in the ward. So this is developing, improving on our care plan, and also improving on the training that we give to our nurses. So that's one of the areas that we're sort of focusing on to ensure, and then ongoing work, because improving time in range is just like an ongoing encompassing work, but making sure whilst we're doing that we're bridging any health inequalities that there are in our area.
Well, that's a crucial piece of work, and we look forward to hearing more about how that goes. Thank you all for taking the time to be here today to tell us about your improvements. We've covered a range of different aspects of running an effective QI project within a busy paediatric diabetes service. This has included enabling a learning environment through having a dedicated space for team reflection and discussion, having a strategy for measurement, collecting real-time data, and finding out whether these changes are making an improvement. Having a solid approach to project management, such as the organisation of tasks and promoting team ownership of different parts of your project. Lastly, having clear improvement aim, which is specific, measurable, achievable, relevant, and time-bound. That's the end of our podcast, but lastly, just a quick message from the Diabetes Quality Programme. The Quality Programme have a number of peer reviews to complete over the next few months. If you're a consultant, nurse, dietitian, or psychologist within a service that is a member of the Children and Young People's Diabetes Quality Programme, then we invite you to become a peer reviewer. The key benefits of being a peer reviewer are the opportunity to meet and work with colleagues across paediatric diabetes, to learn good practice from other teams, and to use this to benefit your own service, to support and provide feedback to other teams. You'll be provided with training, and our peer review coordinators will guide you through the process. For more information, please contact diabetes.quality@rcpch.ac.uk.